Hello, and welcome to this Clinical Care Options Hematology podcast. I'm your host, Jervis Constanzo. In today's episode, we're joined by Dr. Brady Stein from the Northwestern Feinberg School of Medicine in Chicago, Illinois. He will be discussing key clinical highlights and takeaways from studies in myeloproliferative neoplasms, MPNs, that were presented at the 2024 ASCO Annual Meeting in Chicago, Illinois, and the EHA 2024 Congress in Madrid, Spain. This episode is part of a larger educational program entitled Congress to Clinic, Myeloid Malignancies Clinical Advances Journal Club on Emerging MPN, MDS, and AML Data. For more information on Dr. Stein, along with a link to the complete program, including downloadable slide sets and clinical commentaries, please visit the show notes for this episode. Now let's hear what the expert has to say on data presented for MPN at the 2024 ASCO and EHA conferences.
So first, we're going to talk about essential thrombocythemia. Perhaps this is the MPN that is the most indolent of the three that I'm going to talk about today. The goals of therapy to manage symptoms and primarily to reduce the risk for thrombosis and/or hemorrhage. Transformation of progression is important. I put as a goal of therapy the hope that we can prevent or delay transformation, but I'm not sure that we can accomplish this with our current medications. And of course, the last major goal of therapy is to manage special situations. And for the ET patient, that might be helping manage a younger patient through her pregnancy. For all patients with the primary care doctor, we co-manage and help address cardiovascular risk factors. And then for ET patients, we use aspirin a little bit more selectively compared to PV. We favor this in patients who have microvascular disturbances, cardiovascular risk, and or JAK2 mutations. We use aspirin again selectively in patients who have CALR mutations or extreme thrombocytosis because of the bleeding risk. And then we make a decision about cytoreduction, reserving it more typically for higher risk patients, higher vascular risk patients, and we think more about hydroxyurea and interferon for higher risk patients who are older than 60 with JAK2 mutations or have had a thrombotic event. For lower risk patients, we might observe and use aspirin unless they have a thrombotic event, a bleeding event, symptomatic thrombocytosis, or perhaps refractory vasomotor symptoms. And in that case, we can use cytoreduction. And what we haven't used in the front line, we can choose to use in the second line, but we have really pretty limited options. In terms of disease burden, again, ET can have a more indolent course than some of the other MPNs. Of course, patients with ET can be asymptomatic, but if you follow the patients, a lot of times they will report symptoms that are cytokine related, vascular related, or perhaps related to disease evolution. And the concerns kind of vary by the decade of illness that they're in. Initially, symptoms above and thrombotic risk, but later there's a risk for disease transformation. And so transformation is the subject of the next abstract. And this is presented at EHA by Dr. Mesa. This was a study looking at progression to MF in patients who had ET. And what's interesting about it is that it's actually a large prospective cohort study. There were 1,237 patients included. And what's important here is that a lot of our data from these relatively rare diseases comes from retrospective studies. And so it's nice to see a prospective cohort study with sufficient follow-up to help address some of the important questions for the field. So these are higher risk ET patients. The question of interest was looking at rates of progression, and a relatively small number of patients progressed in the data set. And that's perhaps because even though this is a longish median time for follow-up for other diseases, for ET, this is a pretty short follow-up if we think about the event of interest here, which is a progression event. The progression events were assessed if a patient had a bone marrow biopsy. Another progression event, of course, was death, appearance of blasts, new or worsening splenomegaly, or blood count abnormalities like leukocytosis, anemia, or thrombocytopenia. In this data set, the progression that occurred was most commonly due to fibrosis, thankfully more so than death or the appearance of blasts or splenomegaly. And in terms of the risk factors for progression, these are not necessarily innovative. These are not necessarily novel. They are fairly intuitive. Progression is most likely in patients with longer disease duration. And then among patients who are entered into the study, those who had higher white counts, lower hemoglobin at enrollment, telling us that at enrollment, maybe their disease necessarily was already on the way, not necessarily ET at the beginning if they're demonstrating leukocytosis and anemia. An important point here is that from the data, this is a real world observational study. So it's just kind of looking at how real-world practices unfold. Only a small subset of patients had actual bone marrow data, so progression rates are underestimated. And what that also could mean is that once the patient has an ET label, perhaps we're stuck with that label and not necessarily seeing that when the patient has ET but anemia and or leukocytosis, that their disease is changing. So there's seemingly an underestimation of progression, perhaps because of lack of performance of bone marrow biopsies. So next, let's move to PV. Similar in some themes, but of course, there are differences in management and treatment options. So for PV, a similar algorithm in that we're hoping to relieve symptoms, reduce thrombosis and hemorrhage risk. Of course, we're hoping to prevent or delay transformation. And similarly, we'd manage special situations, whether they be pregnancy or perhaps managing around the time of surgery. Co-managing cardiovascular risk is clearly important. Aspirin use is more universal rather than selective. We use it unless there's a contraindication because there's data to support. And another key difference is we're going to control the hematocrit, which is important in PV, but not an issue that we should see in ET. We should not see a high hematocrit in ET. If they have that, they probably don't have ET. Cytoreduction, similarly based on vascular risk, which is based on the patient's age and thrombotic event history. So high-risk patients historically are given cytoreduction. In the United States, classically hydroxyurea, but other frontline options include interferon and ropeg interferon, which I'm going to talk about. Lower-risk patients, so the younger patients, are often treated with phlebotomy and aspirin, and then it's a more reactive approach to cytoreduction. If the symptoms worsen, if phlebotomy is poorly tolerated, if there's progressive cytosis, although vaguely defined, they might move on to cytoreduction. Similar choices, frontline, and if the patient has intolerance or resistance, they might move on to a second line. So what I want to do a little bit more is provide some more background for ropeg interferon. This is the newest approved drug for patients with polycythemia vera. It was approved about 2.5 years ago, but for the audience, if you're not familiar, I'm going to share some of this data. The study that led to approval was called the PROUD-PV study, and after enrolling, patients entered into a continuation phase. But essentially, this is a longer-acting interferon. So each generation of interferon keeps improving compared to the last. This is the longest-acting interferon. So a patient would receive this each 2 weeks, and then once the blood counts are normalized after perhaps a year of therapy, they could move to once-monthly injections. So compared to hydroxyurea, this was the control. What you can see is that there were similar hematologic rates at year 1, but with interferon medications, you have to be really patient. The response is somewhat time dependent. So there's separation over time, as you'll see with hematologic responses in terms of complete responses. Thrombosis rates similar, so both hydroxyurea and an interferon could probably similarly suppress thrombosis rates. But the real difference is by year 5, there are molecular responses according to criteria, more so in patients treated with ropeg interferon compared to hydroxyurea. Again, there's a time dependence. You don't necessarily see this early, you see this after years of therapy. So it gives us evidence for clonal activity or suppressing a clone, but what's always been a question is there any clinical relevance to reducing the allele burden in this disease? Another background study looking at this drug in all low-risk patients, so this was restricted for lower-risk patients, comparing the drug to phlebotomy and aspirin. And this study was important in that it sort of, I think, signals possible paradigm shift, at least in a university setting. The study was stopped early because patients had better outcomes, better maintenance of their blood counts if ropeg interferon was added to the standard of care compared to doing phlebotomy alone. So better hematocrit control, perhaps better symptom control. Here, the allele burden reduction was pretty modest, but again, this was only a short follow-up and there's a time dependence to changes in allele burden. Tolerable, in my own experience, definitely more tolerable than recombinant interferon, and seemingly a little bit more tolerable than pegylated interferon, though those have not been directly compared in any kind of study. So this is the background of the drug. And again, getting to the question, is there a practical correlate to a molecular response? Is it meaningful? Is it clinically relevant? So this is an abstract that was presented by a French colleague, Dr. Brady at the European Hematology Meeting, and essentially looked at patients who were part of the PROUD-PV study, which I presented 2 slides ago, looking at the correlations between event-free survival and molecular response. So these were early PV patients. These patients were newly diagnosed. They were largely younger than 60, and the risk events of interest were thrombosis, progression to MF, AML, or death. This is a low event rate, but this is what happens in PV clinical trials. Thankfully, the event rates are low, but you need a really long time to observe event rates. So that makes clinical studies in these arenas very difficult. But the event rates were lower, and the risk events were significantly lower in patients who had a molecular response at the last time point compared to no molecular response. So patients who had a molecular response had a risk event rate of 3.8%. Not shown here is the risk event rate for patients who lacked a molecular response. It was closer to 15%. So this is kind of some of the first evidence with this drug that there's a practical correlate that you can control counts, and that inducing a molecular response, which is like a 50% decrease in the variant allele fraction, that can correlate with improvement in the disease course, whether it's thrombosis risk reduction or potentially progression events. And patients who were treated with ROPEG interferon compared to control, which was hydroxyurea, were spending more time in molecular response. I think that the study is important in that we have some clinical relevance to a significant allele burden reduction with this drug. So next, we're going to move to MF. And at the most of these large congresses, ASH, ASCO, and EHA, the focus is often on MF because MF has historically had more unmet treatment needs compared to the others. Historically, it's less indolent, more aggressive, but there's been more and more approved therapies. We're up to 4 approved therapies from MF since 2011. So the non-transplant approach to myelofibrosis is essentially based on the predominant aspect of the patient's disease burden. So we're palliating these patients, we're supporting these patients, we're figuring out what the worst part of the illness is for them and trying to treat that accordingly. So when we group these patients, some are low risk, early asymptomatic. We might observe them or perhaps a clinical trial or consider a low dose interferon. The majority of patients have symptoms and have some disease burden that has to be addressed. And so it could be those inflammatory symptoms and or symptomatic splenomegaly, which JAK inhibitors are the foundation of therapy. There's 4. Ruxolitinib was the first. The others that are approved, we're going to go into a little bit more detail discussing, but the other approved are pacritinib, pacritinib, and momelotinib. And each now has kind of a niche, so we can tailor therapy based on patient characteristics. Where we've largely struggled is trying to treat anemia. We had abstracts early on presented about treating MDS-associated anemia. We've really struggled as a field to try to treat MF-associated anemia. You can see what we've done in the past are things like EPO-stimulating agents, danazol, which has been used since the late 1980s, steroids, maybe immunomodulatory drugs like thalidomide and lenalidomide, but none of us have been impressed with efficacy or durability. So we're going to talk more about a paradigm shift in how we treat cytopenic MF patients as well. So what I want to do is go over the abstracts, and this is one from Dr. Monti at the European Hematology Meeting. This looks at the baseline characteristics, treatment patterns, and health outcomes for patients from a real-world sample from Canada, UK, and Germany, MF patients treated with fedratinib. And so just under 200 patients who had discontinued ruxolitinib were evaluated. These are patients who largely had ruxolitinib failures, which could be defined as resistance or intolerance. The key summary here is that these patients who are rux intolerant or resistant treated in a real world, after 6 months, 42% had resolution of their symptoms using a patient-reported outcome tool or using the symptoms that we would assess in a patient outcome tool. And among those patients who had moderate splenomegaly, palpable 11 to 20 centimeters below the rib margin, that's pretty marked. Comparing baseline to after 6 months, the proportion of patients who had moderate splenomegaly decreased from 56 to 17.8%. Massive splenomegaly decreased from 24.5 to 5.9%. And overall, about 2/3 had some reduction in spleen size at a median of 4 months. So the authors here show us real-world findings that tell us about potential clinical benefit for this agent. And I'll tell you how I'd use this agent in sequence, where I'd put this in the order. Momentum is another study that was a phase 3 study comparing momelotinib to danazol in patients with myelofibrosis. This is the study that helped secure the approval of momelotinib. This is the most recently approved JAK inhibitor. This JAK inhibitor can address splenomegaly, can address inflammatory symptoms, but what's unique is that patients here have anemia responses, whether it's liberation from transfusion or in non-transfusion dependent patients, and clinical improvements in hemoglobin, which is about a 2 gram per deciliter improvement. I bring up this abstract just to kind of introduce you to this drug if you haven't heard about it. and to help show you where it falls into the treatment sequence for patients with MF. This abstract looks at kind of the long-term benefit of an anemia-directed therapy such as momelotinib. So it's compared against danazol and looked at, in this abstract, overall survival and leukemia-free survival. But what they did was use a statistical model that could help better estimate overall survival and leukemia-free survival that would have been observed, because these patients all crossed over at 6 months from danazol to momelotinib. So once there's a crossover, it becomes difficult with that data to figure out the more precise overall survival and leukemia-free survival. So a statistical method was used to look at the impact of anemia-directed therapy. And when using this statistical model, the risk of death was reduced by 22%, the risk of leukemia perhaps reduced by 36% at best. So the idea here is just that anemia is an adverse prognostic indicator, and anemia-directed therapy, when successful, may translate into long-term benefit for these patients, possibly overall survival. The next drug that we have available is called pacritinib. Pacritinib is unique in that it can be used in patients who have any degree of thrombocytopenia. So you could have an MF patient with a platelet count of 15,000, and you can use this JAK inhibitor. That's clearly previously an unmet need that patients had. A patient who had severe thrombocytopenia to that degree had no options before this drug. So this drug fits that niche of patients who have cytopenia. Now, that patient who has MF with severe thrombocytopenia is also quite likely to have significant anemia as well. These are going to be the more cytopenic MF patients that you're going to see in your clinics. So this was a study, a retrospective analysis presented that looked at the outcomes with pacritinib compared to best available therapy, which was typically ruxolitinib, in bicytopenic patients. So these patients had a median platelet count of 46,000, a median hemoglobin of 8.4. They also had marked splenomegaly. The spleen length was at least about 14 to 15 and a half centimeters. So again, they have all the characteristics that you see in an advanced MF patient population. Now, when we use this drug, which fulfills a niche, you can see that compared to best available therapy, the bar graph shows improvements compared to best available therapy with regard to spleen volume reduction, symptom improvements, the patient's impression of how they're doing on the drug, the patient's global impression change is mostly very much and much improved. And then really importantly, though not statistically significant, that's because the numbers, there's more patients who have transfusion independence with pacritinib compared to ruxolitinib. So again, important treatment for bicytopenic MF patients, patients who have anemia and thrombocytopenia. So transplant is another aspect of MF care that we have to discuss, but only about 5 to 10% of patients with MF really ever get to transplant. So it's a very selected patient population. But regardless of the selected patient population, patients going to transplant are likely to have marked splenomegaly and myelofibrosis. And these are factors that impact performance status, especially if we think about the former, and both could potentially delay engraftment. So we worry about patients who have marked splenomegaly going into transplant, and there's debate about whether something aggressive should be done to the spleen prior to transplant. So that introduces the next abstract, and it looks at volumetrics to assess the spleen volume and then how the spleen volume correlates with outcomes after transplantation. So this is a study done by a major transplant center in California, the City of Hope. 130 patients were included. Patients were analyzed based on the degree of spleen volume. So moderate or less was less than 3,000 cc's. Massive was more than 3,000 cc's or mLs on a volumetric computer analysis. And then the volume was assessed at intervals up to 12 months post-transplant. Most patients had moderate splenomegaly as opposed to massive. If we look at the spleen volume prior to transplant, the median was 1,150 cc's. The median reduction was almost 50%. What's interesting is that this takes time. 3 to 6 months post-transplant was when this is observed. So the splenomegaly is not going to resolve right away. The same is true if you're looking at a study of bone marrow fibrosis. It can resolve, but it can take some time. So it's not an immediate resolution, but it can, of course, and will resolve with a successful transplant. What's really interesting here, or what's important here, is that there really wasn't any significant impact on the degree of splenomegaly, whether it was 1,000 cc's, 1,000 to 2,000 cc's, 2,000 to 3,000, or massive. There wasn't any significant impact or correlation between spleen volume in overall survival, disease-free survival, relapse, non-relapse mortality, or neutrophil engraftment. So what does that mean? I'll share that in the conclusion or the takeaway, but we should be really reluctant to do something aggressive like splenectomy prior to transplant. We have to be mindful that 2 phase 3 combination studies have been completed and they are presented at each of the major congresses. So if you're going to the meeting or if you're listening to presentations like this, these studies should be on our radar because these were phase 3 that were completed with some positive data. The positive data here, to summarize, is that when you use a combination, pelabresib here plus ruxolitinib, this is a BET inhibitor, compared to placebo plus ruxolitinib and a JAK inhibitor naive patient population, outcomes at week 24, spleen volume reduction of 35% using CT/MRI. The response is almost double when you use this combination compared to placebo plus Rux. And the loss of response, the responses seem to be more durable over time in the combination treatment. So again, important to see that there's potential synergy with the combination. And I think a similar theme in another phase 3 study presented by my colleague, Dr. Pemaraju from the MD Anderson, a similar combination study. This is looking at navitoclax plus ruxolitinib versus Rux versus placebo. Long-term safety and efficacy data presented here, 20.3 months of follow-up. A pretty high-risk patient population, 80% or more with higher risk or higher than intermediate to risk, 50% have high molecular risk mutations. And similar, there might be synergy in terms of the combination if we see the ability to address splenomegaly compared to using ruxolitinib alone. The key finding here may be a subtle improvement in variant allele fractions, no real change in symptom score. But again, be on the lookout for these combinations because phase 3s have been completed and the data is now with the FDA, so we'll have to see what happens with these combinations. So my key takeaways before we conclude, one for ET, looking at Dr. Messa's abstract, ET correlates with indolence, but progression can occur. The most common risk factor is disease duration. A highlight of this study is really the fact that a large prospective real-world data set has been done. This is a prospective cohort. Hopefully we'll learn a lot more from this cohort that is over 1,000 patients in 5 years of follow-up. ET lags behind other MPNs in terms of development of novel therapeutics, and it's likely or largely the indolence and relative rarity of meeting endpoints that limit assessment of hard outcomes. And so that limits the enthusiasm to conduct large randomized clinical trials, hard outcomes like thrombosis, progression, survival. So we need well-conducted prospective studies that will hopefully also have a biobank that will help us understand or identify surrogates for these endpoints because these endpoints are difficult to wait for or observe in clinical trials. Lots of patients, lots of time, lots of money required to do that. For PV, I bring up the abstract on ROPEC interferon to bring up the potential paradigm shift. We've always been reactive using vascular risk, perhaps undertreating newly diagnosed younger patients, but we're seeing an improved drug that induces hematological responses as well as molecular responses. And we're seeing that these molecular responses have meaning potentially because fewer risk events like thrombosis or progression might be observed. So the paradigm shift is perhaps not treating only on vascular risk, but treating based on the presence of the disease, not looking at age or thrombosis history, but intervening early to suppress the clone. For MF, I promised I'd present a JAK inhibitor sequencing slide. We have 4 agents. So the way I view it, all comers, the first line, ruxolitinib makes good sense, but pacritinib can be used for thrombocytopenic patients. Second line, fedratinib, because of the data here shown as salvage in patients with Rux resistance or tolerance. It is approved for first line, but I see the data as most impressive for second line. Another second line is a patient has significant thrombocytopenia, pacritinib. Anemic patients, momelotinib or pacritinib, especially if they're bicytopenic, these become important options. And the paradigm should shift towards using these drugs, perhaps rather than using EPO, prednisone, danazol for the anemic patients. So we can tailor to individual needs. MF patients who go on to transplant, this is a very selected, younger fit patient population, but likely has marked splenomegaly. The abstract here shows that spleen volumes don't necessarily negatively impact transplant outcomes. So be very careful about splenectomy and or radiation prior to transplant. And lastly, be aware of combination treatments. JAK-STAT dysregulation is nearly universal, if not universal, in MPNs, but there are so many other targetable pathways. And the foundation is a JAK inhibitor, but adding a novel combinatory partner makes a lot of sense. We're seeing synergy. I think what we need to see is not just spleen volume reduction, but other aspects of addressing disease burdens. Should we switch patients from Hydrea to Ropeg, and who would you not start on Ropeg for PV? The Ropeg trials included older patients as well. So historically, we're using interferons for younger patients, but older patients were included in the clinical trial. In clinical practice, I have a number of patients who are older than 60 or 65 who are tolerating the medication well. So I'm not sure there's an age restriction for the medication. I think the patients we would not start would be those patients who have more classical contraindications to interferons. Severe autoimmune disease, uncontrolled depression or anxiety would be two considerations that I might be a little reluctant to use an interferon for PV. Would I switch all patients? Not necessarily. I still think there's some selection involved. But if I were to have a discussion for a newly diagnosed patient that needs a treatment, I'd bring up both agents for sure and introduce the concept of molecular response now that we can potentially show a patient a clinical outcome of meaningful interest if there is a response. Dosing of momelotinib, and do you increase incrementally or dose initially? Pacritinib, so I try to give the full doses based on the package inserts for both initially. The pacritinib, you have a severely thrombocytopenic patient population that likely needs it, but the platelet count, it may not improve, but it should not significantly worsen. So I wouldn't use that as limiting my dose. And momelotinib, I'd go by the package insert as well. Again, the best outcome for treating anemia is probably going to be giving it at the standard dose, which is 200 milligrams daily. So I'd start with the standard rather than starting low and incrementally increase. Now, with ruxolitinib, because anemia has been a side effect, as is thrombocytopenia, you can make an argument for an MF patient with severe anemia if you're using that drug to increase incrementally, and a lot of us have done that. At what level of thrombocytosis with no reactive cause do you need to start treatment is a good question. The platelet count predicts for bleeding, but it has a poor predictor for thrombosis. If we think about use of cytoreduction, it's more based on vascular risk and symptoms. But if we're strictly looking at a platelet count, a lot of us will use a 1.5 million, even in the absence of higher risk or symptoms, to consider starting treatment. Have I seen patients who do not respond at all to newer agents in MF? Absolutely. Yes, you can have a primary refractory patient. I think the question of how long do you stop before treatment is a great one. Interestingly, with Rux, you can see responses very, very early, right? Weeks to a month, you can start to see relief of inflammation and improvement in spleen size. But with Rux, historically, we'd give 3 to 6 months before, if we saw nothing, we would stop.
Thank you, Dr. Stein, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Congress to Clinic, Myeloid Malignancies Clinical Advances Journal Club on Emerging MPN, MDS, and AML data, and to download a slide set associated with this discussion, please click the link in the show notes. As always, thanks for listening.